All right, let's get right into this explainer. Today, we're decoding high-yield surgical emergencies. We're going to use a series of rapid-fire clinical vignettes to translate complex surgical decision-making into clear takeaways you can easily lock into your memory.
We're covering 5 main topics today: pancreatic cancer and palliation, pyogenic and perianal abscesses, gallstone ileus management, trauma and perforated viscus, and finally, closed-loop obstruction and injury.
Starting right off with Section 1, pancreatic cancer and palliation. Here's our first clinical scenario. You've got a 62-year-old male being evaluated for a potentially resectable adenocarcinoma right at the head of the pancreas. We need to know which staging finding is an absolute contraindication to a Whipple procedure.
Well, it comes down to the definition of unresectable disease. If the tumor demonstrates full circumferential encasement, meaning it wraps more than 180 degrees around the superior mesenteric artery or the celiac axis, you absolutely cannot do the surgery. That finding is an absolute contraindication.
To put that into perspective, there's a massive difference between arterial and venous involvement here. Like we just said, arterial encasement over 180 degrees is a total no-go. But venous involvement, say less than 180 degrees of contact with a portal vein or superior mesenteric vein, is actually considered borderline resectable, simply because those veins can be reconstructed. Oh, and if the gastroduodenal artery is involved, that's totally fine, since we routinely ligate that during a standard Whipple anyway.
But what if the disease is completely unresectable? We immediately shift gears to palliative management. If you know it's unresectable beforehand, the non-operative route is an ERCP with an indwelling biliary stent, just to relieve that severe obstructive jaundice. On the flip side, if you're already in the operating room, you've opened the patient up, and only then discover it's unresectable, you pivot right then and there to an operative open double bypass, specifically a choledochojejunostomy and gastrojejunostomy.
Moving smoothly to Section 2, pyogenic and perianal abscesses. Next question for you. What is clinically documented as the most common underlying cause or portal of entry for developing a pyogenic liver abscess? The answer is ascending cholangitis. This is an infection of the biliary tract, usually kicked off by gallstones or strictures, and it literally accounts for about 35% of all pyogenic liver abscess cases. So, how do we manage these intra-abdominal abscesses? It really depends entirely on the patient's stability. If they're stable and have a simple, unilocular, accessible fluid collection, percutaneous drainage is your preferred move. But if the patient is unstable, septic, and has multiloculated, widely distributed cavities full of thick debris, percutaneous drains simply won't cut it, and open laparotomy is absolutely mandated to clear that out. And while we're on the topic of abscesses, let's look at perianal abscesses. In non-diabetic patients, these are primarily driven by E. coli. The absolute crucial takeaway here is that they require immediate surgical incision and drainage right over the site of maximum fluctuation. You cannot wait around for antibiotics to kick in, or you seriously risk the development of necrotizing fasciitis.
All right, Section 3, gallstone ileus management.
Here is your next clinical puzzle. When you're looking at abdominal imaging and you see branching gas tracking up within the biliary tree, which is known as pneumobilia, what condition is that characteristically associated with?
It's characteristically associated with a gallstone ileus. You really want to lock down your core diagnostic triads for these emergencies. For Behr-Hof's syndrome, you're looking at Mackler's triad. For acute cholangitis, it's Charcot's triad. But for a gallstone ileus, the hallmark is Rigler's triad, a small bowel obstruction, pneumobilia, and an ectopic radiopaque stone. When it comes to the surgical sequence for a gallstone ileus, there are very strict rules. Step 1, perform a laparotomy to relieve the obstruction. Step 2, find the stone and gently milk it proximally into healthy bowel. Step 3, extract it through a longitudinal enterotomy. And step 4, this is absolutely critical. Strictly avoid exploring or closing the choledoenteric fistula. If you mess with it, you risk a massive ductal injury. Next up, Section 4, trauma and perforated viscus. Picture this scenario. A 22-year-old male is brought in after a bad car crash. He's got a rigid abdomen. When you percuss his upper abdomen, there is a complete obliteration of his normal liver dullness. What is the most likely underlying visceral injury here? You're looking at a traumatic intestinal perforation. Basically, free gas has escaped from a hollow viscus and pooled right between the anterior chest wall and the liver surface. that massive pocket of gas completely masks the liver's natural physiological dullness on percussion. It's a massive red flag. Now, you'll see a very similar physiological phenomenon in non-trauma cases, specifically with a perforated peptic ulcer. The classic presentation includes a history of high-dose daily NSAID use, followed by the sudden onset of agonizing epigastric pain. The patient will exhibit somatic immobility, meaning they're lying perfectly rigid and still to avoid any painful peritoneal friction. Their abdomen will be board-like, and just like our trauma case, an erect chest X-ray will reveal a distinct crescent of free air sitting right beneath the right hemidiaphragm. And for our final round, Section 5, Closed Loop Obstruction and Injury. Let's look at a closed-loop intestinal obstruction, which is where both the proximal and distal ends of a bowel segment are occluded. If this remains untreated, what complication is most likely to occur incredibly rapidly? The immediate danger is ischemic gangrene and perforation. Because it's a closed loop, the escalating intraluminal pressure violently exceeds the capillary perfusion pressure. This causes microvascular occlusion and rapid cecal necrosis. It's all dictated by Laplace's law. All right, our last clinical scenario. A 55-year-old male develops a rigid, silent abdomen immediately following a diagnostic colonoscopy. What is the absolute best management strategy for this iatrogenic injury? It requires immediate surgical exploration, which perfectly brings us to this powerful reminder. The surgeon's ultimate tool is recognizing when not to operate versus when to rush to the OR. While a tiny microperforation without peritonitis might be managed conservatively, generalized peritonitis demands an urgent laparotomy. Mastering surgery is ultimately about mastering that clinical judgment. Keep questioning the consensus, and we'll catch you in the next explainer.